William Hersh. My pleasure to introduce him. He was the inaugural chair for the department from 2003 to 2022. And he is well known for both education and research. And so we were pleased to have him give us a talk today on artificial intelligence. And he served as the director of our graduate program, which is the oldest and largest in the field. And some of you may know that our alumni have gone on to create their own programs, a testament to Bill and his program. So we thank Bill for his incredible work there. He's also an accomplished researcher. His main efforts are in the area of information retrieval, also known as searching, applied to biomedicine. He's authored over 200 papers and abstracts, and some of you may know about his book, Information Retrieval, A Biomedical and Health Perspective, 4th edition, came out in 2020. His current work focuses on applications of search techniques to electronic health record data, aiming to improve patient cohort discovery and amplification of signals of rare diseases. Welcome, Bill.
Thank you.
Pizza in the room, so make sure those people are here. Sign in and grab the pizza.
This is good. We can see how many people. Okay, there's 19 people online. Okay, well, thank you, Karen, for that kind introduction, although you all know me, so I appreciate you keeping it short so I can actually devote more time to the talk. This talk is well, in October, I was invited to give a talk to the OHSU Educators Collaborative, which is a group of faculty who are interested in innovation and related issues in education. They wanted to hear about AI. So I think I was talking to Vishnu, and I know some of you attended that talk, which was virtual. And Vishnu said, well, maybe you should give it here. But actually, as I was preparing for it the last week or two, I decided that it probably wouldn't be good to repeat it. In fact, one of the challenges with AI is that, it's like every week, there's a new paper or something that comes out that changes it. But you'll actually notice I made a subtle change to the title. I swapped out health professions for informatics because I thought I would focus more on informatics. I think that health professions education is actually important to us in informatics because we are the people, among others, who are educating health profession, medical students, nursing students, et cetera, on informatics and AI. But there's also issues important in informatics. And plus, I actually have a little, I wouldn't call it data, but a little experience I can report because I actually tried, and actually, I guess there's some people in this room that took my course this fall to actually do something with AI to kind of confront this issue. So I'll talk about that as well, and then hopefully leave some time for comments and discussion. So my objectives, so it's slightly different from the previous talk, but I'll kind of give the 40,000-foot overview of AI, just kind of level set people. I'll try to go through that quickly. Then talk about some of the key issues for AI and informatics education, and then also talk about opportunities, which I always like to encourage students to do. So this is a revision of the talk that I gave earlier, and I'll try to leave maybe 10 or 15 minutes for discussion. So you're always supposed to give a financial disclosure. I don't have any stock or companies. And actually, I stole this from Jim Semino, who used this at the AMIA meeting. But I don't know. I do pay $20 a month to OpenAI. Is that a conflict? I'll let you decide, and then you can decide whether you want to believe what I have to say. So, okay, just to, again, get up to the 40,000-foot level, you all probably know this. So, AI, I always like the definitions that talk about, basically information systems and algorithms capable of performing tasks associated with human intelligence. And there's all kinds of different variations on that. Lately, we've been grouping AI into two broad categories, predictive AI, that's focused on things like diagnosis and treatment and things like that, aiming to predict some sort of output. And that's kind of the main work that's gone on until literally about a year ago, although actually people were doing generative AI before ChatGPT was released. But generative AI generating new output, particularly based on prompts, not only text, images, other things. And of course, a large part of the success is due to machine learning, which are computer programs that learn without being explicitly programmed. And the most success, some of you know more about this than I do, with things like deep learning based on many layered neural networks and so forth. You know, when you get up in the years, you can start like reminiscing about the days. But anyways, I entered the field right at the very tail end of the first era of AI. And AI had a lot of hype back then. You know, of course, we didn't have social media and everything else, but there was hype, you know, getting Congress to support research in AI. The ethnic group that we were worried about in the 1980s was the Japanese. You know, so we need to compete with Japan. We can't lose this battle. You know, it's the future, da, da, da. But anyways, the first era of AI actually was a big part of the field, and then it all came to an end. So there was the famous Ledley and Lusted paper that looked at that aiming to model physician reasoning through a combination of symbolic logic, so symbols representing findings and diagnoses and treatments and things like that, and then probabilities. Homer Warner, the late Homer Warner, was the first to develop a mathematical model for a disease, in this case, congenital heart disease. The real thrust of the effort took part in the 60s and 70s, which I was alive then, although very young, not yet working in the field. But the expert systems that were basically computer programs aiming to mimic expertise, human expertise. And there's a nice book that was recently published. And by the way, I have a PDF of my references and slides on my website. I will give you the link at the end, but most of you know how to find my website. And anyways, and this led to the rule-based system. So that's why is it? Hold on, let's go on. And in fact, Ted Shortliff, one of the founders of our field, his PhD dissertation in the late 60s, early 70s, he was an MD PhD student at Stanford, developed the first rule-based expert systems, and others followed on. And then another approach developed disease profiles and scoring algorithms, the famous Internist 1 system, and also another one called DXplain. But all this started to peter out right when I was a fellow, just like some of you, in the late 1980s. I was an NLM fellow, and you know, basically trying to build these huge knowledge resources and then develop computer programs to act on them was difficult to scale and to be sustainable. And actually in the early 1990s, the whole, we actually stopped talking about AI. In fact, some people call that kind of time period in the 90s and through the turn of the century, the AI winter. And about the only piece of it that remains is the clinical decision support that we see in electronic health records. But most of the rest of it has gone away. And it clearly trying to build the knowledge of especially something as complex as medicine is actually something humans can't do. Now, there were people doing machine learning back then, but there was no data. There were the computers of the day were, you know, less powerful than, you know, like my Apple Watch, our phones and so forth. But then, so AI kind of died. In fact, one way to look at it is I almost got to the point where I was going to throw this part of my introductory course, which a number of you in this room have taken, BMI 510, just out of the course because, you know, AI wasn't a thing. I never quite did, though. I always thought it should stay. And obviously, I'm glad I did. And now it's a big part of the course again. But anyways, so really what happened in this second era of AI is the machine learning, massive amounts of data available, the internet, electronic health records, all the images, and of course more powerful computers and networks. And then the breakthroughs in deep learning, and Sir Geoffrey Hinton, who actually is known in medicine for saying about 7 or 8 years ago, though he has since recanted his statement, that there's no future in fields like radiology. It's all going to be done by AI. He has stepped back from that, but he developed the algorithms that enabled deep learning to classify images, and that was the kind of first success in this new era. So being able to look at an image of an eye and the inside of an eye and diagnose diabetes, diabetic retinopathy, a chest X-ray, pneumonia, tuberculosis, pathology images, cancer, and skin lesions, things like melanoma. And AI algorithms, as you all know, are very good at that now. They perform, with clean data sets and not in the real world, but in kind of controlled conditions, as well as human experts. And it's not just limited to imaging. So predicting adverse events in hospitals. Actually, this is a big one now. Generating clinical notes. This has become a commercial thing. I know Anessa is very involved in that. An age-old problem in biology, predicting protein folding from amino acid sequences, which could never be done, but then machine learning algorithms can do it quite effectively. Being able to classify cancers, sometimes cancers of unknown primary, predicting survival, predicting patient courses. The last two ones I think are interesting. Basically reconstructing voice from functional MRI images. And then also another paper recently, mapping chemicals that are in the air to the odors that we as humans perceive. So AI and machine learning are getting in everywhere. Another interesting thing is that AI can see things that we as humans can't. And one of my favorite people to follow is Eric Topol, and he has written a lot about this, and there's all these references. But for example, looking at a picture of a retina and discerning age, biological sex, race. Actually, Aaron Coiner, one of our former students, was able to do this. That we can't see as humans. We look inside the eye with a ophthalmoscope and we can't tell these things. Same thing with electrocardiograms, age, biological sex, risk stratification, chronic kidney disease, left ventricular systolic dysfunction. I came across a paper the other day, Parkinson's disease. There's something that machine learning algorithms can process about an EKG that are not perfectly predictive, but highly predictive Parkinson's disease. Same thing for chest X-rays, race, cardiac function, diabetes, and even voice data. Some of us in this room are involved in the Bridge to AI project on voice biomarkers. And there was a paper published recently that machine learning algorithms can discern differences, like, for example, does someone have type 2 diabetes? So some of these are potentially important. Others raise Pandora's box issues like, race and biological sex and things like that. And then, so that's predictive AI. And then there's generative AI, which November 30th, 2022, I remember the day, ChatGPT became available. Most of you know how these large language models work. They basically take massive amounts of text that is on the internet, in books, other places, and use transformer models that basically build these models. And they basically work by predicting the next word in sequence. And when you have billions or trillions of words, you can do that quite effectively. And in addition, when you measure the attention, kind of what the word's about. And then these systems are fine-tuned with a process called reinforcement learning from human feedback, although there's also new methods that are being developed. And then everything revolves around prompting, and I will talk more about prompting. It's a skill that we all need to have, being able to prompt AI systems. And generative AI is more than Chat GPT. So for example, Bing, the search engine, actually uses a version of GPT-4. Google, you can sign up and you can get generative AI that comes with your Google search. Chat GPT also can be extended. There's plugins. For example, Scholar AI, which searches PubMed. It doesn't do it, I don't think, really well. There's another system that will generate PowerPoint presentations from text, which I don't think it works that well. But and then another one that summarizes scientific papers. And then, for those of us who work in information retrieval, the new hot thing is something called retrieval augmented generation. One of the problems with generative AI is that it hallucinates sometimes. It gives the wrong answer. The idea behind retrieval augmented generation is to basically do a search, an information retrieval search, and actually use that in the prompt. And there's not a lot of good research results yet, but that's the promise of that technique. And then another thing that's happening is, can we use smaller language models, also ones that are more focused? For example, right now, the general models work best for medical tasks, but in the future, can we train large language or even smaller language models with medical records, things like that? So how well do these systems do? I call it the USMLE arms race, because one of the first accomplishments was basically passing. There's sample questions for medical students when they go through training. They take step 1 in their second year, step 2 in their fourth year, and then as an intern, step 3. There's sample questions on the USMLE site. In fact, there's a data set that machine learning researchers use, and you can see how well the performance has increased. It was a big deal a year ago when GPT 3.5, the original GPT and Chat GPT, got 60%, which is around a passing grade. But now the numbers are up to 90%. There was a paper published by a group at Microsoft Research and using GPT-4 and also some very specific kind of prompting. And I assume this arms race will go on because Google's system, MedPalm, is up there. There will probably be others that come. And then it's actually not only the medical licensing exam, it's actually all these board exams, including that some people in this room will take someday, the clinical informatics board exam. GPT 3.5 gets a score of about 60%. That was a paper published by Yakuma Crystal a few months ago. I actually, and then other fields, radiology, neurology. There's one field that it didn't achieve a quote unquote passing grade, which is neonatology, but they use GPT 3.5. I actually know Andrew Beam, the author, so I asked him a week ago, and he said, oh yeah, we have a paper under review. We got 90% with GPT-4. So GPT-4 is right now the kind of the gold standard for most tasks, although there will, these are still relatively early days. And I've encouraged Yakuma Crystal to use GPT-4 on the clinical informatics board exam. I'd be interested to see. But it's not just answering board exams questions, it's answering other kinds of medical questions. There's a ton of papers out there. I reference a few here, solving clinical cases with basically ChatGPT, although now most research is done using either GPT-4 or Google system. Oftentimes comparable to, but not necessarily better than the experts. And Other things, communicating with patients, being able to answer questions that get posted in social media forums, being able to generate letters. Actually, Epic and other systems now are starting to implement this, generating draft letters that physicians can use. There was one study, although I know there's some dispute about it, but that the letters coming out of the generative AI were rated as more empathetic than what physicians wrote. Generating surgical consents, and then actually closing the loop with predictive AI, classifying chest X-ray findings based on a combination of images and reports using large generalized models. And then also this latter one, which I think about these days as one gets in the years of cardiovascular risk, but predicting cardiovascular risk from things like the Framingham models. But there are some downsides. You're all probably familiar with these. Clearly, one of this is the fabrication, some call hallucinations. There have been a number of different studies looking at the references that get generated. I actually did this myself in the very early days. I published it in my blog. I probably should have tried to publish it as paper, but anyways, other people did. Making up references or having errors within them. Another issue is that since these large language models are based on the language that is out there, perpetuating harmful race-based medicine. This has always been an issue with when you apply machine learning to the text of the world. Also, creating compelling disinformation and humans not being able to distinguish the information coming from large language models. And then these large language models, again, reflecting the content and the bias. And even there's issues about intellectual property. And in fact, actually, I realized this just a few weeks ago, that I've actually contributed to the training of many of these large language models, because our server, dmice.ohsu.edu, is part of the colossal clean crawled corpus, which is this large corpus of essentially a web crawl that is used for this kind of research. Maybe my intellectual property has been stolen, but I'm okay with that. I do put it out there. And then there's the issue of detecting GPT. I'm going to talk about, the academic issues. That's kind of the main focus of this talk. But some of them do well. It also depends on the type of material, the type of question that's being asked, or the type of content coming out. One interesting side finding is that non-native English writers are more likely to have their text classified as being AI generated, which also raises some issues of bias. And the flip side of that, of humans being able to discern AI writing, are not able to do that well. And there are some issues with AI in general. One is that this was a paper in Annals of Internal Medicine a few months ago. Once we start deploying these models and using them, we're changing the world, because these models are now part of the world. And so how do we handle that? Another issue are things like automation bias. So if you have, and I'm not just talking about generative AI here, but radiologists being biased actually in either direction, either relying too much on the AI interpretation or not enough. Then issues when you move it out to the real world. Many of these systems there's been a lot of projects using them in rural areas, not only in the US, but around the world. But you get into challenges when of trying to collect decent, for example, retinal images when you're out in as this paper reported, in rural Thailand or rural India. Probably it would happen many places around the US too. And then the issue of reproducibility of these algorithms. These systems are always changing. These systems are developed by big companies, and so there's not a lot of transparency that we as users can see. And then you have, again, this issue of data bias, and then also data leakage, where you have instances where some of the data in the test collection, in the test part of the data set, are in the model. So usually the way you do these models is you have training data to train the model, then you set it to work with the test data. But if some of the training has taken place with the test data, then you're potentially biasing the model. That's called data leakage. And there's a nice paper that talks about all the different kinds of data leakage that can occur and how to look for it. So will AI help or hinder healthcare? Probably many of you have seen me throw the famous picture up of Dr. McCoy, who had a lot of technology at his disposal, but was the empathetic physician taking care of his patients. Is that the future we'll see, or will it be more ominous? Well, one thing is that despite all the hype, there's actually relatively modest real-world use of AI. There was a survey published by the MGMA, which represents medical groups, and only 21% of medical groups reported that they're using, I suppose it depends on how you define AI, but not a whole lot of use in the real world yet. And if you ask these groups what their priorities are, it's like, yeah, they're concerned about AI, but they're much more concerned about EHR usability, patient communications, and billing over AI. Maybe that'll change in the future. What about the evidence base? There have been 3 now, and I try to follow these things closely, systematic reviews of randomized controlled trials of predictive AI systems. And you can kind of generalize from the results. One is that there's a pittance of clinical trials compared to model papers. So each of these 3 systematic reviews, depending on how they included and excluded things, has about 40 to 80 randomized controlled trials in their systematic review, as opposed to if you do a PubMed search on predictive AI models, you'll get thousands of hits. In fact, you'll find thousands of systematic reviews of model papers. So there's a lot of model papers out there, and there's a lot fewer studies in the real world. And in all of these systematic reviews, they found concerns about risk of bias, and not all the results were positive. Some were positive, some were negative. So AI is not quite ready to replace physicians. And Curtis Langlotz, who's a radiologist at Stanford, another friend of mine, has been quoted, AI won't replace radiologists, but radiologists who use AI will replace radiologists who don't. And I always tell people, plug in your health profession there. And all of this must be implemented in responsible ways. And our David Dorr had a really nice perspective in JAMA earlier this year, talking about responsible use of AI, and he's involved in the committee with the National Academy of Medicine. So just a few examples of what we need to do to build the evidence base, or some of the things we need to think about. So it's still a hot topic, but it's not as hot of a topic as it was about 10 years ago when the CMS, the funder for Medicare, said, hospitals, you need to reduce the number of patients who get readmitted, and we're actually going to penalize you. So everyone and their brother set off to develop algorithms, and it turns out you can actually predict it very easily, who's likely to be readmitted. But that's not the end of it. You actually have to show that you can take this data and implement some kind of intervention. And in fact, there was a big randomized controlled trial in Switzerland published earlier this year. They put this whole infrastructure around it and actually had no difference in hospital readmissions. And Bob Wachter, who also writes a lot about AI, noted that just because we can predict something does not mean we can necessarily do something about it. Likewise, models for predicting development of chronic kidney disease. That's been another area. There's also a kind of side issue with that is the use of race in those algorithms. But the main issue is, how, can you predict kidney disease? And then if you can predict it, can you do anything about it? And so new models have been developed, a lot of the work trying to get race out of the equation. But in the process, and these new models are very accurate, but people are raising the question, well, okay, if we have these models, do we know that they're going to do anything? Because if we start looking at early kidney disease, we might subject people to intravenous contrast and imaging studies, which of course is detrimental to kidneys, patient anxiety, unnecessary testing. And this editorial that accompanied this paper is what we really need are clinical trials to validate use of the model. And then one more, this has probably been the most clinically studied area of AI, which is detection of polyps. So I probably shouldn't keep talking about age, but when you reach a certain age, you have that test where they look in your colon. And it turns out that the endoscopists miss polyps, especially small ones. And the goal of colonoscopy is to find those polyps early, especially the ones that have the potential to develop into colon cancer and remove them. Well, it turns out that AI assistants are actually very good at helping point colonoscopists to polyps that are out there, that are in there, I should say, in the colon. The problem, though, is that the ones they detect tend to be the non-cancerous ones, and it's not clear that those develop into cancerous ones. And in fact, there was a randomized control trial that basically compared, I can't remember what the control group was, but the intervention was the AI assistant saying, look here, and there was no difference in detection of advanced colorectal neoplasias. And so there's always an accompanying editorial that said, there's challenges in implementing AI in the real world, which may impact the results, but we must build the evidence base if we're going to detect it. So let me then shift gears to informatics education. And so the two main questions I'm going to ask, what is the optimal use of generative AI in learning, and kind of a sub-question, when might its use be detrimental or unethical, and then what opportunities are there? Does anyone under 30 know what I'm holding in my hand?
Under 30.
Under 30. Is that, maybe there's no one in here who's under 30. How about under 40? Yeah, you guys probably know what that is. Anyways, I was in high school in the mid 1970s when the shift was taking place. I learned how to use a slide rule in my high school chemistry class, but by the time I got to physics, they're like, okay, you can use calculators now. And there was so much debate. I don't know if the generative AI thing is the same, but I was just thinking about that. But anyways, I keep my slide rule as a prop. Now I can take selfies with it. Anyways, so, but this is an issue, and any of us who teach, and all of us in this room either teach or take courses, there's a lot of things that can be done in the way we teach using generative AI. Not only answering the kinds of multiple choice questions that I give, but programming assignments. ChatGPT is very effective at generating code. And there's a lot of angst in the educational world about not only the biomedical education world, but the world as a whole. One person who I actually like to follow on Twitter, and he also has a Substack, is Ethan Mollick. He was one of the first people to start, addressing this issue head on. And So I'm going to talk a little bit about what I've done, and then, you know, we'll throw it open for conversation at the end. But so we do now actually have a generative AI policy from the provost, which wasn't widely publicized, but I learned about it recently. Pardon me?
Where is it? I've been looking.
Oh, and I have the URL to it. Although it's on O2, so you know you have to either be on VPN or I don't know why they don't make it public. Anyways, and I, as some of you know, developed one for my course, and then one of my colleagues at the AMIA meeting said, you know, we need to play offense on this. You know, we need to actually engage the use of this. So I tried it this term, and I'll report my quote unquote results. It would be a stretch to really call them results, but oh, and then this was published just, I don't know, about a week or two ago. They asked 1,000 college students. It's a website, so you know it's not scientific, but I'm sure they found 1,000 real students and asked them. But you know, if you look at the numbers, 56% of college students have used AI tools to help complete assignments or exams. 53% has had coursework that requires it to be used. 79% have had at least one instructor that discussed the use. And these students, over half of them, at least according to this survey, believe that using these tools to complete assignments or exams is cheating or plagiarism. Obviously, if the instructor allows it, it's not cheating or plagiarism, but and then my school has a policy, and you see here, that's 58%. And so Malik, this is what actually kind of motivated me. He published this paper called Assigning AI, and he talks about the different ways that you can use AI and the role that students would play and the benefit and the risk. And he clearly acknowledges there is risk, but he, like many instructors, has started to incorporate AI, especially generative AI, into his courses, his teaching. I actually, there was an incident this last term where there was some concern that, you know, actually many people in this room have taken my course, about, you know, using the discussion forums on Sakai and the whether there were students who were using ChatGPT to generate text for that. And my view on the discussion forum is it's really a place for people to talk. I don't think it's a good use, but I had no policy about it. So actually, I actually have to attribute Steve Bedrick here, who had also developed earlier a policy for his courses that tend to be more programming oriented. And so I am using his ideas and others that I'd read online, came up with this policy, and in particular for the specific activities of the course. So for the discussion forums, I'm like, please, you really shouldn't be doing this. For things like homework and the final exam, I tend to prefer open book kinds of homeworks and exams because I think it's more important for people to apply the knowledge than to memorize it. But obviously, if you have ChatGPT at your disposal, that you know, potentially undermines that approach. I'm not, well, I wasn't too worried about ChatGPT writing term papers, but I'm more worried about that now. Not so much writing it beginning to end, but people chunking things together and encouraging people not. And telling students, if you have a question about what you think is appropriate, you know, talk to me or the instructor. Certainly we expect work to be students' own original work. So here is the provost policy, and if you get these slides, you can just click on the link, and I'll show you how to get the slides at the end. The provost policy is good. It's a little more general, and I think probably for a lot of courses, we're going to need more specific guidance on what we think is appropriate or not. So what did I do? I thought, okay, well, let's address this head on. So many of you know the BMI 510 course that many of you have taken. There's another version of it called 10 by 10 that's more of a continuing education course, and the assignment in that course is shorter. But basically, I said, okay, if students want to try to use and learn how to prompt generative AI, let's do it. So I set some parameters. I said, so first you have to choose at least 3 topics. Generally in the term paper, I tell students that, pick an area of informatics you're interested in and go beyond what we cover in the course, and you will hopefully learn from it and write a good paper. So I thought for this, I said, okay, pick at least 3 topics that you have an interest in or questions beyond what's in the course. You need to use at least 2 different generative AI systems. I suggested Perplexity AI as the second one because that actually gives you references, and that's what most people ended up doing. I didn't mean to steer them in that way. I said, there's also generative AI embedded in search engines. You should have at least 3 iterations, so the initial prompt and 2 more. And then you should analyze the output with a page or 2 of what did it get right? Are there things it got wrong? Are there things it should have said but didn't? And if the systems generate references, are those references real or are they confabulated? And then if those are references, are they good ones? Are there other ones that should have been there? And then in the 10 by 10 course, it was just a scaled back version. They just had to have 1 conversation with the 3 iterations and the analysis. So here's my results. I should actually put it in quotes because I didn't get IRB. But anyways, I'm talking very general terms here. So I gave students the option of doing this or just the regular assignment. So in the 10 by 10 course, they write a 2 to 3 page short paper on a problem that they want to use informatics to solve. 6 of the 21 students opted for the for the generative AI option. And this actually surprised me. In BMI 510, only 3 out of 15 chose it. And the rest wrote papers, very good papers. And that's fine. The goal was not to make them do this. So how do I assess the situation? So for the most part, the students carried out the assignment as I instructed them. For 510, where they had to use a second LLM, most of them used Perplexity AI. That probably is because that's what I gave as an example. I thought all of their assessments of the output were good. They discussed, what came out, what should have been, what might have been there in addition. One student did a phenomenal job, should have cited, and there's I think there's over a page of references of, things that were important to this topic. And then another student actually created this nice table of features or attributes and evaluated them in comparing the 2 different language models. So I'll probably continue this, but it is just interesting. So let me close for a few minutes and then we'll stop. The other thing I just want to talk about is another educational issue, which I think are opportunities for informatics students. These are still the early days, thousands of model papers, 40 randomized controlled trials, and there's still a lot that we need to know about implementation, evaluation, and risks. So, and I think the translational kind of framework applies here. So, as you know, in medical schools, we have basic science and clinical science. And basic scientists are across the street in the labs doing experiments with tissue cultures and mice and whatever. They identify the promising drugs, the promising tests and things like that. But it doesn't stop there. It needs to actually cross the street into the hospital so that it's translated with real world patients. And then we need to generate evidence, as we tend to call it on the clinical side, that demonstrate there's some kind of value to a patient for their disease, for their health, or for the healthcare system. And I see in my blog, when the Bridge to AI project was first starting, they were encouraging people to make suggestions for grand challenges. And I said, this should be a grand challenge, translational AI. And I was actually asked to present at this virtual meeting. But as those of you who know Bridge to AI, they chose a very different path. So I didn't encourage them to take up this, although I think most people would agree that this is important. And in fact, we're starting to see now some studies that involve users. This was a paper that came out of Microsoft research, or no, I'm sorry, came out of Google using their large language models, where they actually gave real clinicians, physicians, a case vignette and asked them to generate a differential diagnosis, a list of possibilities. Interestingly enough, you see this graph in the lower left. The large language model actually did best. The clinician assisted by the large language model did second best. The the control group was basically, they said to the clinicians, you can go search Google or PubMed. They did worse, and clinicians who had no assistance at all were down at the bottom. They were also very happy to point out in the lower right that the Google LLM did better than GPT-4 for this task. And the numbers just kind of reiterate what the graphs show. This isn't a perfect study, but I think it's a good direction that we should be heading. How do real world clinicians use this stuff? And in fact, again, pulling my age out of here, maybe experience. If I look back at some of the studies that I did, some of my early research, it's probably not that big of a deal these days, but how well do clinicians use search systems? Back in the day when not everyone, had it on your phone and whatever. And so we found out some interesting things. So one is that the differences in things we ask the users to do, like could they answer questions, overwhelmed the metrics that we look at the system, things like recall and precision, how many relevant articles, things like that. We also found that just because your search system retrieves something that answers the question right there in front of their face on the screen, doesn't mean that they answer the question correctly. And that there was some not insignificant number of instances where they do worse after they have the intervention. We would have them answer the question without anything, and then they could look it up in, I think it was one of these was using a medical textbook, the other one Medline. And in some not insignificant number of cases, they went from correct to incorrect answer. So just in conclusion, and then I will open it up to you all. I do believe that AI is going to profoundly impact everything we do, despite the hype. But right now, the day-to-day impact is small, and we need to figure out how to implement these systems in the real world. Both educators and students need to figure out how generative AI is going to be used. If it keeps people from learning, I'm not one of those people that thinks everything needs to be in your brain, but people need to understand things to be able to critically think and so forth. And we don't want AI tools to worsen that. And then, I think there's a lot of opportunities for informatics students. So I will open the floor to questions. I will, before I do that though, I just want to mention that I got interviewed on a podcast that was just published yesterday called Health and Explainable AI. And you can go listen to that. I also wanted to let people know that my textbook, which some of you know about, is going to be available for viewing on the library website. Not downloading, but viewing. And I'll publicize this, but you have to log in with your OHSU credentials. And then I'm also going to be on another podcast that some of you know, Kevin Johnson, who on what life is like after leadership. Anyway, so I will stop at that point and answer any, or would like to hear comments. And if I have anything to add, I will. I think we can see. Can we see the chat here? Or maybe, I don't know if anyone's. Anyway, someone out there is going to have to speak up. Okay, but let me just open the floor. I'd be curious. Any thoughts, comments about what I've talked about? Yeah, go ahead.
Logan Jones, hospitalist, lots of education dabbling. In charge of competency-based education portfolio for the School of Medicine. We do a lot of student assessment as well. And one of the things that most interests me in AI is actually using the language model for asynchronous opportunities for student reps, whether it be clinical or other learning experiences, and how large language models can help facilitate the problem we have in education if you do written assessments and provide some type of assessment input. You either have to pay a person to sit around and read a lot of text, which becomes costly and non-reproducible. How we interject large language models to be able to evaluate the text and provide a reliable, reproducible score and assessment on that information.
Yeah, that's a great question. That's a great research question. We need to find an informatics student to. No, yeah, I mean, I have read a number of papers talking about using large language models in like simulation, you know, of generating cases, things like that. Grading, you know, evaluating, I think is a little bit more challenging because, you know, then what is the gold standard? There's another interesting finding that large language model systems, when they are asked to evaluate the output of large language models, tend to rate their own model the highest. So if you ask GPT-4, you know, you give it different kinds of text, it'll rank the stuff that came out of GPT-4. Likewise, Llama, the Google system. That's a good question. I don't know if anyone else has any answers. I don't know, Steve.
The reliable and reproducible are not adjectives that we use about large language models from a technical standpoint. And just to echo what Bill said, the reason they do that is because when we ask an LLM to rate something, or what it's actually computationally doing is measuring statistical likelihood of the actual words that are in the text box. And so that's why if it looks like output it would have produced, we'll give it a higher score, totally independent of any kind of ontological or factual reality of what the content is.
Yeah.
So it seems hard to think about how, like that's part of why using it for assessment. The other issue of using it for assessment is because of all of this, it's going to be basically strongly biased towards frequent or likely outcomes. So anything that deviates from what is seen frequently is going to implicitly have a statistical bias against outputting. So complicated for that.
Would it help to, if it was fine-tuned on prior assessments?
Probably.
That's the approach I've been trying to take, is give it a rubric, give it a massive amount of data that I've got from school of medicine, merge them and say, these are the results. If they result in this, they'll come on this rubric. Now here's a new data set and try and
Rubrics are good. Anything you do to make it more of a internally grounded question, like grounded within the text that it's looking at, that'll help with reliability. But
Any other? We can't see the chat, so I don't know
I
if.
have that open.
Oh, okay. Are there any questions in the chat?
Not yet.
Any other? Yeah,
Sort of my name is Nori. I'm one of the.
great.
I mean, I have a very sort of basic understanding of AI. It's at my age, it's also very difficult to kind of comprehend sort of how it works. I guess one question I have is, to what degree is language actually a limiting factor? Because it seems like language for us humans is, sort of a way to put complex thoughts in a way that can translate to communicate to somebody else. It feels like for now, a lot of the input is based on language.
Yeah.
But like you're saying, in a facility, things are shifting, right? People can now diagnose, the program can diagnose diabetes and incidents just based on an EKG. We can look at things that we cannot even perceive. And at what point does one start to worry that it might just bypass that interaction and just move just to much more measurable parameters? In other words, if a computer can just observe a patient sitting in an emergency room for an hour, instead of trying to understand the communication between a provider and the patient, to kind of come up with some sort of algorithm. Like, I feel like that's the part that scares me the most, is that
I mean, I guess,
language is so like clunky. It's
yeah.
it's like coloring with 4 colors when in fact you have
Yeah.
an entire.
Well, I mean, it's funny because no one really knows for sure why these large language models work so well. No one can there's a guy named Stephen Wolfram who's a mathematician, has, worked in machine learning for many years. And he wrote this small book, basically saying that we don't really know for sure what's going on here, but something about, giving, massive numbers of words, so massive amounts of language to these models, and whatever kind of training is going on with them leads them to sound very human. And the question is, is there actual sentient intelligence there, or is it just a statistical thing that these words are most likely to follow these other words? I don't know that we know. My view, again, maybe I'm too old, but I don't see in my lifetime any of these systems replacing physicians. Now, being intelligent assistants, I think is probably going to be a role at some point. Someone walks into the emergency department, and you have to be careful about human design, because you don't want that automation bias that, here's the patient, and, Dr. So-and-so, and here's what the computer thinks. There might be better ways to do that so that you're not biased, but because you've heard what the computer thinks. But at some point, the computer may well be helpful, because we all know that physicians are far from perfect, in terms of, did you think about this? Or, there's a rare disease that has these kind of symptoms and things like these kind of findings and things like that. So I think it will ultimately come down to, to how they're used. Clearly they work very well. There's no question about that. But the question is how they will be used in a way that will benefit patient care, and also, benefit the work of physicians. Because if you're never having to make decisions anymore, then your thinking processes are going to become rusty. But I don't know. That's just some kind of random thoughts. Sure, Steve.
Well, there's a question in the chat that actually follows up nicely on that.
Sure. Can you?
If anybody has.
Hmm.
So this is from Raz. There have been discussions about ambient AI scribing and the role that learners, med students, residents, et cetera, should play in implementation. Any thoughts on the active placing thoughts on notes for learners versus the fact that note writing is clearly going in this direction? I think that's just to and please chime in the chat if I'm incorrectly interpreting, but it sounds like that's asking a little bit about how are people going to learn properly, or will the AI learn from student notes that are perhaps not ideal, right?
Yeah. Well, and I think, well, I think the notes thing is interesting, because, there's another thing we've learned from now about 15 years of using electronic health records, is that we have made life a lot more difficult for physicians and probably other clinicians too, in terms of the time it takes, to enter notes. Back in the day when I saw patients, either we would scribble short notes on a piece of paper, or we could pick up the phone and dictate, and then some transcriptionist somewhere would transcribe it, and then a day or two later it would show up in our mailbox, printed on a piece of paper. And then in the transition to electronic health records, we've made physicians become the transcribers, and that's led to a lot of burnout. And so part of the value of these automated note generating systems is that they hopefully will make life easier. It require less time, so physicians don't have to go home at night and finish up their charting and so forth. And I know that Vanessa just did some research showing, if I tell me if I don't interpret it right, but that at least GPT-4 is not quite ready for prime time to do that. But there are commercial products, including products that OHSU is implementing. Do you have anything to add to that, or?
I know a competitor of DAX is a Bridge, and they are have been implemented at Emory, and they allow medical students and residents to use the technology. And it's interesting because their spin, or what they are saying about it, is that depending on your level of training, you're really focusing on different areas of the interview. So you send a medical student in, they're going to nail social history. They're going to really get the alcoholic history, tobacco use. They're very good and more comfortable doing that. Their differential and what their assessment and plan is probably not as robust, but that's an area which is going to be edited, and hopefully before kind of signing in and going iteratively into the model would be fixed before being trained on it. Hopefully. We don't know. Yeah. What they also said was a benefit is that you actually get to truly see what was asked. So as an attending, you don't have to then go back and ask the smoking history all over again because it was captured. And so there's greater overlay, and therefore the attending, by the time the medical student and the resident have gone through, can target the true assessment and plan as to moving forward.
Yeah, Gretchen, you were gonna.
And even backing up a little bit from that, what we discovered is that having students try to write notes early in the first 2 years, they really didn't understand what goes in, what's the difference between a review of systems and a physical exam. Maybe now that's moot. Maybe this is going to shift the reliance on that age-old perhaps. So I don't know.
Yeah. When I remember when I was a medical student, like we were expected to write these tomes on patients, pages and pages of stuff, which probably no one should be doing. But as a medical student, though, you could impress your attending physician by every last thing you asked or examined and every last possible differential diagnosis. But that kind of skill is not really good for practicing physicians, where things need to be a lot more succinct. We're actually a little bit past the time. I'm happy to stick around. I know there's a fellows, I think there's a fellow.
Done for the term, so I don't know.
Oh, okay.
But everybody may have to read things.
Yeah, so if people want to go, that's fine. I can stick around. If you go to if you want to get these slides, they're on my webpage, billhersh.info, or drop me an email, or maybe actually I'll send the link around there. They're on the DMICE server, so maybe someday these two will train the next generation of large language model. Anyways, thank you all.
Thank you, Bill.